Haskins.
Good afternoon. I'd like to thank SAGES for inviting me to be a part of this session. Today, I'll be discussing the use of mesh in emergent ventral hernia repair, effects on early patient morbidity and mortality. I have no disclosures for this presentation. It is safe to say that seeing a patient in the general surgery clinic for a first-time reducible ventral hernia is a relatively straightforward clinical scenario that most of us feel comfortable managing. However, when seeing this same patient in the emergency department at 2:30 in the morning due to progression of their hernia to incarceration or strangulation, it may also be safe to say that some of us are left wondering how best to treat this patient. Complicating the approach to the emergent ventral hernia repair is the fact that ventral hernia recurrence is increased not only in those patients who undergo primary suture repair, but also in those patients who experience a postoperative surgical site infection and with each subsequent hernia repair. In other words, the clinical challenge to the emergent ventral hernia repair patient is finding the balance between minimizing the risk of postoperative surgical site infection while providing for a long-term durable hernia repair. Which leads us to the purpose of our study. Intuitively, the use of mesh during emergent ventral hernia repair should lead to a decrease in hernia recurrence as long as the risk of postoperative surgical site infection is not increased with its utilization. Therefore, the purpose of our study was to investigate the independent effect of mesh utilization on 30-day wound-related morbidity and additional 30-day patient morbidity and mortality outcomes. In order to answer this question, we used the NSQIP database from the years 2005 through 2013. All initial and recurrent ventral hernia repairs for incarceration and strangulation were included. To ensure that non-emergent cases were excluded from our analysis, only those cases with the emergency variable encoded yes within the NSQIP database were included. Finally, as a majority of the literature detailing the use of mesh during ventral hernia repair has been described in clean cases, and the idea of prosthetic reinforcement is well accepted in this scenario, only CDC wound classes 2, 3, and 4 were included. In addition to excluding CDC wound class 1, patients with disseminated cancer, those with recent chemotherapy or radiation therapy, patients with bleeding disorders, and those pregnant at the time of operation were also excluded from our analysis. The association of mesh with 30-day patient morbidity and mortality outcomes was initially investigated in univariate analysis using between-group t-tests and chi-square analysis. For those outcomes that had a significant association with mesh, these associations were further investigated in multivariate regression analysis using a backwards elimination process to control for relevant covariates. The association of mesh with 30-day patient morbidity and mortality outcomes was stratified by CDC wound class. A total of 2,449 patients underwent emergent ventral hernia repair from the years 2005 through 2013. These patients were then divided into their respective CDC wound class. 1,357 patients had CDC wound class 2, 587 patients had CDC wound class 3, and 505 patients had CDC wound class 4. Each CDC wound class was then divided into those patients who underwent emergent ventral hernia repair with mesh and those who underwent emergent ventral hernia repair without mesh. Approximately 1/4 of patients in each CDC wound class underwent emergent ventral hernia repair with mesh. Within each CDC wound class, comparisons were then made between those patients who underwent emergent ventral hernia repair with mesh to those who underwent emergent ventral hernia repair without mesh in terms of preoperative patient variables, intraoperative variables, 30-day wound-related morbidity, and additional 30-day patient morbidity and mortality outcomes. We first looked at CDC wound class 2. In terms of preoperative patient variables, patients who underwent ventral hernia repair with mesh had a significantly higher BMI, were less likely to have undergone previous percutaneous coronary artery intervention, and were more likely to have diabetes. In terms of intraoperative variables, those patients who underwent ventral hernia repair with mesh had a significantly longer operative time and were more likely to undergo ventral hernia repair with component separation. Despite the additional risk factors for wound-related morbidity, as well as a longer operative time in more complex hernia repairs, patients who underwent ventral hernia repair with mesh did not differ from those who underwent ventral hernia repair without mesh in terms of 30-day wound-related morbidity or additional 30-day patient morbidity and mortality outcomes. Next, we looked at CDC wound class 3. In terms of preoperative patient variables, patients who underwent ventral hernia repair with mesh had a significantly higher BMI than those who underwent ventral hernia repair without mesh. Similar to CDC Wound Class 2, patients in CDC Wound Class 3 who underwent ventral hernia repair with mesh had a significantly longer operative time and were more likely to undergo ventral hernia repair with component separation. Despite a higher BMI, longer operative time, and more complex hernia repairs, patients who underwent ventral hernia repair with mesh did not differ from those who underwent ventral hernia repair without mesh in terms of 30-day wound-related morbidity. In terms of additional 30-day patient morbidity and mortality outcomes, patients who underwent ventral hernia repair with mesh were significantly more likely to return to the operating room than those who underwent ventral hernia repair without mesh. However, when the CPT and ICD-9 codes were reviewed for the indication for returning to the operating room, no patient returned to the operating room for explantation of infected mesh, revision of their original hernia repair, or repair of a hernia recurrence. Finally, we looked at CDC Wound Class 4. In terms of preoperative patient variables, patients who underwent ventral hernia repair with mesh had a significantly higher serum albumin level than those who underwent ventral hernia repair without mesh. Similar to CDC Wound Classes 2 and 3, patients who underwent ventral hernia repair with mesh in CDC Wound Class 4 had a significantly longer operative time and were more likely to undergo ventral hernia repair with component separation. Again, despite the longer operative time and more complex hernia repairs, patients who underwent ventral hernia repair with mesh did not differ from those who underwent ventral hernia repair without mesh in terms of 30-day wound-related morbidity or additional 30-day patient morbidity and mortality outcomes. In conclusion, patients who undergo emergent ventral hernia repair with mesh have a longer operative time, undergo more complex hernia repairs, and have increased risk factors for wound-related morbidity, including a higher BMI and diabetes in CDC Wound Classes 2 and 3. Nevertheless, the utilization of mesh in emergent ventral hernia repair can be safely performed in CDC Wound Classes 2, 3, and 4 without an increased risk of 30-day wound-related morbidity or additional 30-day patient morbidity or mortality.